Good morning, everybody. My name is Michael Watson. I'm an improvement advisor in the mental health intensive support team. I've worked in the team for the last 7 years since the team was started up, and prior to that I spent about 5 years working in the elective care for physical health intensive support team. And before that, my background is in acute hospital management. I'm here today to lead you into the latest in our programme of support for elective recovery webinar series. We're here today to talk about improving patient flow. As you can see, we've got the usual Menti QR code on the screen, so please do use your smartphone or tablet or whatever you use to scan the code in order to access the Menti polls, which we'll be using throughout the presentation. You can also access the Menti website, menti.com, and use the code on the screen there, 76974930, and that code will be repeated across the slides. Please do interact on our Menti because it brings an added dimension of richness to our presentation, and we know that you like to increase the amount of interaction with the team. Next slide, please. So, as I said, the Menti QR code remains there. So today we're talking about our resources for improving patient flow in community mental health services. As it says here, this is a really big topic. So in the next hour and a half, we're going to pack it in as tightly as we can, but we really will be presenting a fairly high level summary and focusing in a bit more detail on how to get started and on governance. So we're not going to attempt to answer all of your questions, although if you put questions in the Q&A, we will try to answer all of your questions. We're not going to try and cover the entirety of this subject. We're trying to do a reasonable introduction, and we'll have some discussion towards the end about any areas in which we might want to go into further detail for the future. As ever, please do put your comments and questions in the Q&A box. If it's something burning, then we'll try to address it in the course of the presentation. If not, we will pick it up at the end in the Q&A section. We are an improvement team, and we're really keen to keep refining and updating our resources as we're deploying them. All of the information here is available on our Futures site, and the information on our Futures site is regularly updated. So please do ensure that you're signed up to our Futures site and that you patrol it on the regular to keep up with our latest updates. Detailed guidance on the specific interventions and best practice is all available on the Futures page as well. Next slide, please. So, for those of you that don't know our team, and we do know from the feedback questionnaires that we get at the end of each of these programs that a significant number of people who join the webinars do so for the first time. So if you're sick of hearing this preamble, then please do complete the feedback questionnaire at the end and let us know that you've attended one before. So we are the mental health intensive support team. We're a small expert quality improvement team, senior managers and clinicians who support the NHS, delivering improvements in population health, quality, value for money in mental health care, learning disability and autism. We've all got senior experience of delivery, operationally and clinically, and the professional registrants within the team also have significant experience acting as an expert clinical resource. So we deploy our range of experience and skills to help you to improve your safety, timeliness, equity, efficiency and effectiveness and patient-centeredness of your care delivery in mental health care, learning disability and autism. Next slide, please. So this is the 5th webinar in our programme of support for mental health elective recovery. So elective care in this context meaning non-urgent and emergency care, so delivery of services which are planned in advance. So we developed this programme of resources to support elective recovery in the wake of COVID and in recognition of ongoing pressures in terms of service delivery and workforce. Our intention is to try to help you to do as much as you can with the resources that you have to improve quality experience and outcomes for your patients through improving access, waiting times, utilisation of resources, fidelity to best practice, and help you to identify issues, identify themes, and to develop improvements. This programme has been developed by us based on our many years of diagnostic reviews into a wide range of mental health services and our significant experience of working on site in a number of mental health systems and our own personal experiences of working as senior managers and clinicians in mental health providers. We've also borrowed some methodology and approaches from our colleagues in the elective care programme, including their post-COVID elective recovery programme for the acute sector. Next slide, please. So as I said, this is the 5th of our modules on elective recovery support. We've already had pathway mapping, optimising capacity, sustainable waiting lists, and the introduction one, beg your pardon, and you've still got commissioning, access policy, and patient tracking to look forward to in the new year. And our hope is that with this range of approaches, we'll give you all the tools that you need to make the best of the resources that you've got access to in your services, and to deliver better resources, better services for your patients. So now I'm going to hand over to my colleague, Simon, please.
Thanks, Michael. Hi, good morning, everybody. My name is Simon Bristow. I'm a mental health nurse by background. I've been in the team for 3 and something years now, and prior to that, I spent as part of a couple of decades working across various different aspects of mental health service provision. So could I have the next slide, please? From our last webinar, we had some helpful feedback that you guys wanted more sort of visual stimulation within the presentation, and more sort of talking around that. And we previously had feedback on more on delivering, monitoring delivered outcomes. So we've done a big focus on the governance and data side of this today, because it's a really important part of the patient flow stuff. So hopefully you will find this useful. We are going to pause when we get into my colleague Caroline's session later, and ask, after we've been through the main body of the content, and ask for colleagues to put up their hands and come on camera to reflect on how what they're hearing reflects, and in terms of what practice and developmental need is in their areas. So please do prepare yourselves for that if you've got stuff that you want to talk about, either things that you're really that you've done that you're proud of, or things that you don't know where to start with and trying to unpick. Then we'd really love to hear from you. We are going to put these slides, the slides and the recordings up on the Future NHS platform. We've also been putting the recordings up on YouTube, but we will cut out any Q&A and sort of system feedback stuff from the YouTube version, so you don't need to worry about being broadcast to the world. As Michael said, there's a huge body of content here, so we're going to try and cover off the high level points. So a lack of understanding about the flow of patients through mental health services is a long-standing and wicked problem for both adults and children's services, and it needs to be addressed in order for us to be able to deliver the national transformation objectives. If there was a single easy solution to that, we would definitely have done it by now. There's just lots of small steps involved in making visible the many issues that make up the whole picture, so we can then target our clinical and managerial resources where they are needed. So the materials that we've put up on the futures page, and we're going to talk about today, are all about understanding what the needs of the individual are, whether what we're doing is helping or not, so that these and why, so that these can be aggregated and analysed using techniques like Pareto analysis to tell the story around what the core issues are that are affecting flow in your system. So, mental health, historically, we've had a reactive and unplanned approach to managing the mismatch between demand and capacity. And this has included, approaches like arbitrary capping of session numbers, raising of access thresholds, especially, or excluding some groups from access to treatment. And technically, these things can improve flow, but they come at an unacceptable cost to outcomes, safety, experience, and equity. So the approach that we describe in these ways of working proposes a different way of managing this than traditionally many services may be used to. Can I have the next slide, please? So within the backlogs module, we talked about quantifying the issues that arise from people who are already waiting and where demand and capacity is out of sync. And the patient tracking list module that's still to come will cover this from a prospective angle. So this module covers the proactive management of progress through pathways and what to do when this isn't happening. So national targets, and usually the local targets also, are focused on the front door of services, and a lot of service time gets taken up with clinically responding to crisis, and that can take priority over other types of activity. So, for example, if you're a CPN and you're feeling overwhelmed in a service that has kind of lost control of patient flow and you've got 80 people on your caseload and what feels like a continual stream of new requests for allocation, the time and the energy to prepare people who are doing relatively well, maybe considered ticking along for discharge, is curtailed, and where you don't have confidence that there's going to be a seamless step up and step down process. There's also a lot of anxiety often around whether patients who are going to be discharged would be able to rapidly re-access services if they were to relapse in the future. And all these factors interplay in a way that produces compound effects, and they all have a momentum of their own that cause ineffective care for people that are already in treatment, and an unintended sort of treatment rationing for people who aren't able to access a service. And this, and generally not being able to provide the care that you want to the standard that you want, is a source of moral injury to staff, and that requires people to try and protect themselves from the pain that causes. And it can manifest in lots of different ways, but it often means that we lose sight of one or more of the patients. So I've heard on many occasions, things like, my patient is the one who is directly in front of me, and my responsibility is to give them the best possible care. And the patients who are waiting for the service are not my patients. They are, the manager's responsibility or the CCG's responsibility, but someone else's responsibility. And the other way a patient commonly gets lost is through overinvestment in our service processes rather than the patient's needs. The demand and capacity is essentially a dynamic equilibrium between patients who start treatment and patients leaving treatment over time. Patients want and deserve purposeful and timely treatment, and patients that get that treatment more quickly have a better experience and better outcomes. And this is the entire premise of the service model transformations and EIP, IAPT, Future in Mind for Children and Young People services, etc. So the oversight over patient flow is what gives us the data to enable us to understand how patients are leaving treatment over time. So without that, we don't have oversight over both parts of the equilibrium. So no matter how good our oversight over the front door is, we've only got half the story. So when things start to get out of sync between demand and flow, we might smell something is burning, and we can see that teams are stressed and caseloads are growing, but we often can't quantify what is causing the fire, how, where, and what it is that we need to do to address it until it's too late. Can I have the next slide, please? So then when patient flow reaches a crisis point, it feels overwhelming, everybody's frantic, it's frankly distressing. There's this feeling of intense pressure, things often feel unsafe, everyone starts to feel like a palpable sense of fear, and it's difficult to know where to start when addressing the underlying problems. And this sense of danger and being out of control drives a sense of needing to take urgent and reactive actions to manage the crisis. So in hospital settings, for example, when there's a bed crisis, it's not uncommon to send in a team, a senior medic and a nurse and a social worker to go around all the wards and work on unblocking issues that would enable patients to be discharged and release beds. And this sort of approach often has some immediate impact in alleviating the kind of current crisis. But if you don't address the underlying issues, then that crisis will recur again in short order. And where there are structural issues and significant mismatches, this often drives a sort of perma-crisis of using reactive approaches to address issues that's demoralizing, stressful, inefficient, and harmful to culture, experience, and safety and outcomes. It can play out in lots of different ways, all at the same time. Erode standards through driving a degree of numbness to normalization of issues and risks, burns people out, and it can drive defensive behavior between individuals, teams, and between whole organizations. Can I have the next slide, please? And so living in a state of reactive crisis response driven activity hinders our ability to think. And the late, great Viktor Frankl talked about the central importance of having space between the stimulus and the response we give to think and to choose our course of action. So this moving from a reactive way of managing patient flow to a proactive approach is the core concept underpinning all of the process stuff that we're going to talk about today. And a fundamental part of taking a proactive approach is generating data on what is happening, where and why. But generating data alone isn't enough to drive improvements. The benefits will be realized from bringing the stakeholders together to address what are going to be both internal and external issues, as inevitably, there are both in any system. And as such, it's critical that we think about this work as a culture change program that will need to involve all stakeholders more than a sort of simple change to processes. So at this point, I'm going to hand over to our colleague, Dr. Ian Davidson, who's joining us from GIRF today, and I'll let Ian introduce himself.
Hi, so I'm Ian Davidson. I'm the National Clinical Lead for Crisis Acute Mental Health in the GIRF programme, which is getting it right first time. And the crucial bit is about getting it right first time. We have, in our physical health care colleagues, they tend to lump urgent and emergency care together. And it's really important we don't do that, because we are primarily a community service with a small inpatient component rather than being a hospital-based service like our physical health care colleagues. As Simon's already said, if we wait till things are in crisis, it doesn't just burn out the people who are in crisis, it doesn't just burn out their families, it doesn't just burn out their support networks in the community, but it burns out our staff, because it's a very stressful position for anyone to be in. So the whole model that GIRF is promoting in terms of mental health pathways is easy in, easy out. In order to do that, we have to break up what's currently in many teams a huge logjam where people can't get in and can't get out. And what's really important is that also then leads to when people start to relapse, and we're dealing with people with relapsing remitting illnesses, so we can predict that relapses are going to occur. When they start to hit relapse and they need some urgent input, the teams are often so bogged down with routine appointments, you can't get an early review by a nurse or an OT or a doctor or anyone else, because everyone's booked up so far in advance. And that is not good elective care. That is poor elective care when everything is so timetabled, nothing else can fit in. So we need to move to the point where we are using the data we've got. We can't at this point very well predict which people are going to relapse in which week, although there are now services starting to look at that data. But what we can predict is that for a given community team, there will be a certain number of people in relapse in any given week. And what we need to do is keep capacity back for them, so when they start to relapse, they are seen within hours or days, not months or longer. Because we are doing brilliantly as a service. Mental health has done extremely well in coping with the extra demand through the crisis stuff that we brought in the last 2 years. And that's brilliant, but we can't keep waiting for everyone to get into crisis. And as you know, one of the most frequent complaints from people is no one listens to me till I'm in crisis. And that's the worst time to try and understand people or to help them. So what we'll be talking about in terms of this, and we'll be coming back to this later, is the need to start looking at your own data, looking at your own services, and starting to allocate a certain amount of capacity for urgent work, which then enables you to do your elective work much more effectively. And I'll hand over at this point.
Thank you, Ian. So our first mentee of the session, you can use the QR code on the screen, or as Michael said, go to the website and enter this code. If you could please hit the little heart on the screen to let us know that you are able to access that, that would be really helpful. So we're going to have a couple of questions now, and then I'm going to talk about the some of the interventions, and then we're going to hear some examples of implementation from one of our colleagues from CNTW. All right, we've got a lot of responses, so can I have the next slide, please? So can we have a straw poll as of now as to how you feel your existing knowledge of effective management of patient flow is? Okay, so we've got some good confidence and some moderate confidence, and some people who feel they've got some developmental needs. This is good, a good range of respondents, and kind of largely clustered around the middle values. So hopefully you'll all take something away from today that is going to be helpful. Lovely. Could I have the next slide, please? So, as I said, this is a real culture change program. How would you feel about whether your organization has the culture, systems and processes required to undertake this work? Okay, so we've got a slightly negative skew at the moment. But, you know, a good spread of somewhat confident upwards, and some people that are very confident. So if you're very confident in this and you feel that you know a lot about it from the previous slide, we would like to hear from you when it comes to the point of putting hands up about what it is that you feel that your organization's doing that makes you very confident about it, because obviously it's not It's not a universal picture, and different people are in different levels of sort of readiness. Okay, lovely. Thank you very much. Could I have the next slide, please? So now we're going to talk a bit about the interventions. Can I have the next slide, please? Okay, so there are 6 process steps for working to improve patient flow, and they're described on this slide. Within the webinar, there isn't time to address each in depth, so we're going to be focusing on steps 1 to 4 as they are applied to implementing what we believe are the high impact actions that we would recommend as starting points. So within these approaches, a core principle is about understanding where there is variation and whether it's warranted or unwarranted. So each person has their own unique set of circumstances, and people often present to mental health services with more than one treatment need. And we need to understand this as part of our assessment and formulation and tailor the way that we plan their care accordingly. So that's a type of warranted variation. But there's also huge variation in clinical practice between departments, between community teams, and between individual clinicians within those teams, even where statistically the patients and the pathways are identical. And the variation between what people get is so big that it just isn't possible to say that all patients within that could be receiving good care. So that's unwarranted variation, and it's a major obstacle to achieving safe, effective patient care and service delivery. And what constitutes warranted versus unwarranted variation in how treatment is delivered will differ between services. So it's one of the things that you will need to define with your clinical and managerial leads in consultations with staff and patients, and in accordance with whatever the evidence base says and your understanding of the population that you're serving with whichever service it is that you're looking at. Can I have the next slide, please? So many of the skills and approaches for triangulating and responding to data as described in steps 4, 5, and 6 on the previous slide are covered via the latter sections of the really excellent Making Data Count Steps training offer that's run by our colleagues in the Making Data Count team, and we highly recommend that whole program. There's also a new 6-week NHS England course on getting started with large-scale change that is enrolling now. This course aims to help participants developing their ability to apply large-scale change approaches, tools and techniques to support organisations' transformation programmes and COVID elective recovery, and also their personal development. And that's going to be running from the 9th of January until the 19th of February, and is completed at participants' own pace. You can join the course from links that are going to be in the NHS England QI learning platform, and they're going to be in the slides that we circulate after this webinar. Could I have the next slide, please? So again, just wanted to signpost to some things here. First of all, you're going to hear later in the programme about model health system data. So we've put a lot of work into working with the model health system team to redevelop the way that the metrics are in there and the way that they work and the way they're collected over the last few years. So please do sign up for Model Health System if you haven't, because it will give you a lot of the data that you are going to need for some of this stuff. There's also the adult policy team's Future NHS page now has the draft clinically ready for discharge guidance and webinar, which will be of interest if for your work looking at inpatient flow. And we also have and the 100-day discharge challenge. There's also demand and capacity teams Future NHS platform, as well as links to the training I've just talked about and various different implementation links. And there's NHSE has loads of quality improvement guidance via the QSARE platform. Really recommend that you check that stuff out. And when you look at our features page, we've linked to the bits where it's particularly relevant on the flow page. Next slide, please. Right. So this is the big slide. This describes each of the approaches contained within the resources that we've made available via Future NHS. So I'm going to try and give you a high-level overview of all of them. So first of all is ensuring that the progress of each patient is reviewed and reported on between each treatment session using structured clinical case management supervision. And from that, you are coding, aggregating, and reporting on the reasons for delays to progress through pathways. So without that sort of oversight, it's difficult to understand what each patient is getting, how they're progressing through the pathway at each point, and whether what we're doing is helpful and what the variation is between all of those things. So that's point one. Secondly is around setting estimated durations of treatment and criteria for discharge for each patient within co-produced, personalised care plans that are based on the strengths, needs, and aspirations of each patient. And without that sort of approach to contracting with patients around what care they're going to receive, we often have is variation in what's offered between different clinicians that we don't have any oversight of. Patients not feeling clear about what it is they're receiving, for how long, and whether we'll know it's effective. And under those circumstances, it's easy for the aims of treatment to drift away from the original needs, because life is complicated and messy. And you know, people develop new needs often during a period of treatment. So national policy, that's point 2. So national policy is oriented around delivering a seamless stepping up and stepping down of patients between services, and that requires a different type of relationship between services than has often happened in the past. So in order to support this, discharges out of the service need to be reported on and monitored against standards. We need to have an equal focus on that, as we do with treatment starts. And if this isn't in place, it's common in services that feel overstretched for patients who are transferring in from other teams to be managed with a lower priority for treatment starts than new patients. And this lack of pull through of patients into a system, into a service in a timely way, often becomes a bottleneck, and that causes a systemic risk to patient flow across the system. Discharge is also a key point of clinical risk. There's a loss of established relationship for the patient and their carers. There's a loss for the clinician. There's a change in accountabilities around ongoing care and treatment. And that can often lead to changes in clinical risk, a lack of clarity about treatment responsibilities from a governance perspective, a lack of understanding around how to access support, feelings of loss, rejection, abandonment. So it's critical that these factors are considered with each patient, and that they inform how the discharge plan is constructed and managed to ensure that patient movement between services is safe. So discharge tracking, point 3. Waiting times to specific treatment starts, including internal waiting times, need to be reported on and monitored against waiting standards using patient tracking lists. Because if waits for entry into specific treatments are not defined, reported on, monitored, then what we often have is bottlenecks and unmanageable waiting lists that are not visible in governance frameworks. So, you know, people get lots of ongoing kind of care coordination while they're waiting 12 months for family therapy, for example. It's a common thing that we see. And finally, using multidisciplinary extended treatment reviews to review the care of patients who have exceeded the expected durations of treatment, and coding, aggregating, and reporting the reasons for delays. So not all patients achieve clinical milestones, not all patients recover with unanticipated treatment periods, and not all treatments are effective for all patients. So if we don't have a multidisciplinary approach to considering how to support patients who may require a different approach to treatment than was originally planned, and the risk of overtreatment or ineffective treatment increases. And this extended treatment review process also assists with the transition from using a broadly case management focused approach within the service to a more purposeful treatment approach, by starting at looking at what the needs of the patients are who have been in the pathways for the longest, and how we might work with them differently. So I've just talked to you a lot about different aspects of work. Can I have the next slide, please? In relation to patient flow, and they all need to be underpinned by different standards. So you might struggle to read this on the screen, but it should be clearer on your mobile device via the Menti. Would be really interested to hear from participants on the call, of all of the stuff that I've just taught you about, which aspects of managing patient flow are you confident that there are clear and locally agreed standards for in your area? So there's 6 options. You can select multiple ones of them. If you're not confident that there's clear standards and processes for any of them, then there's a none of the above option as well. Okay, so we're getting okay, good. We're getting a cluster of things across the reporting. So we've got pretty good representation of clinical case management supervision, how long patients should wait, and how patients should be discharged, but a large cluster also for none of the above. Okay, so responses are still coming in, so I'm reticent to move on, but I don't think it's changing the overall picture. They seem to be our kind of our largest clusters. So work to do around estimated durations of treatment, standardized descriptor codes for delays, and extended treatment reviews, which is fortunate because, can I have the next slide, please? What we're going to talk about today in more detail is the high impact and low resource interventions. These are a suite of resources that have a compound effect when they're used together, so we recommend using all of them, but doing all of them in one go obviously requires a lot of work, and as I said earlier, is a significant culture change. So if you're not currently using these approaches, to get started, what we'd recommend focusing on are the setting of estimated durations of treatment, setting criteria for discharge, and using clinical case management supervision to monitor and report on progress against pathways. And while it's not an optimal way of doing it, it is possible to set develop a set of co-produced local standards, implement the processes, and report on the outputs of the activities without major digital infrastructure work. And that will begin to provide you with a picture of what's going on with the treatments offered and over what duration. If you have these all already in place, then you can move on to the other approaches and refine existing approaches where required, if there's anything in what you hear today that is not currently in place. But the rest of the slides in this section are going to focus on the key aspects of implementing these approaches. There's a whole, for all of the approaches that we've talked about, there is a good practice self-assessment checklist that's on the Future NHS platform. So you'll see it linked to in various different slides throughout this. But if you want to quickly go through and think about where you're at with this in relation to that, that's your tool to use. Can I have the next slide, please? Okay, so first off, for setting estimated durations of treatment, your key things to consider when implementing processes around this are that you'll need to work with patients, carers and clinicians to co-produce standards for how estimated durations of treatment are going to be formulated, agreed with patients, documented and shared with every patient alongside a copy of their assessment and formulation. When you're thinking about how estimated durations of treatment should work within a service, they'll need to be informed by the treatment durations that are set out for the interventions that you're provided, as are described in the pathways and best practice guidance. If treatment is not concluded at the end of an estimated duration of treatment, then you need to have a clinical review and a reformulation of the person's needs. And that review will need to consider whether it's appropriate to continue with the current treatment, whether to discontinue treatment, or whether to offer different interventions. And if you're offering new interventions, then you need to set a new estimated duration of treatment and a new criteria for discharge in accordance with the new interventions that are being offered and the new formulation of their needs. Next slide, please. So secondly is developing a process for agreeing criteria for discharge for patients, Criteria for discharge are the things that you need to achieve in order to enable the person to step down from the service, and that may be to routine care and primary care, or could be continuing their treatment with a less intensive mental health specific service. And key things to consider when developing these are, again, you'll need to work with patients, carers and clinicians to co-produce standards for how they are to be formulated, how they are to be agreed with patients, and how they're to be documented and shared. The approach to that may be taken in different ways. You might want to use specific clinical criteria, or you might want to use routine outcome measures, be it PHQ, GAD9 and GAD7, or goal-based outcomes or dialogue. But the criteria need to align to the expected outputs of the treatment that's being delivered by the service. And patients will also need to be able to initiate early follow-up reviews at any time if their treatment isn't working, or if they have side effects, or if they feel that they've recovered earlier than expected. And that needs to be clearly and consistently communicated to all patients, because it needs to be a bi-directional relationship. Next slide, please. And thirdly is the use of clinical case management supervision to proactively monitor and report on patient progress towards the criteria for discharge, hopefully within the estimated duration of treatment. So clinical case management supervision is a regular structured review of the progress of all patients under each clinician in each service, and the supervisor needs to have the authority, skills and experience to support decisions about whether pathway milestones have been achieved, change the approach being used for care delivery, or instigate the cessation of treatment interventions and discharge. Specific purposeful treatment interventions to be taken before the next supervision to support the patient to make those steps towards discharge must be agreed and documented at every session, and progress against the actions agreed at the last session also need to be reviewed at each session. So these sessions should be supported by current data on what the patient is getting versus what they're expected to, as is described in the little blocks on the slides. And this is best presented using a visual dashboard that's driven by the EPR, but it can be manually captured in Microsoft Office software if you don't have the digital support currently in place to do that. So then bringing these things together, using the estimated durations of treatment and the criteria for discharge, your governance structures need to oversee data that is reported up from caseload management supervision on where, why, and in what quantities patients are exceeding the treatment duration, exceeding the estimated treatment duration, but remaining in the same treatment, or are having changes to treatment, or are discontinuing treatment without achieving recovery goals, or are getting vastly different treatment doses between services and clinicians. And receiving that data will allow you to start asking the questions about what is going on here, what is the variation between them, and do we think that's warranted, or do we think that's unwarranted? How might we want to, what other questions may we want to ask, and what may we want to do about these things? So at this point, I'm going to pause and I'm going to hand over to our colleague, Katie Paul, who is joining us from CNTW today to talk about their experience with using some of these approaches. Thanks, Katie.
Hi everyone. Yes, I'm Katie Paul. I'm a clinical manager within Northumberland SIPS, part of CNTW, and I'm a nurse by background, and I've worked in children's mental health for about 11 years. Just to start off before we get into the presentation, really, it was just to let you all know we've been in really tricky situations, just like every other organisation with wait times. And going back around 8 years ago, we had 2,000 children waiting, some of them up to 2 years for treatment to start. And just as every other service, we've tried waiting list initiatives and being able to recover and improve waits, but then things would slide. We then became successful and being a trailblazer site to be a 4-week wait. We were one of 12 in the country, and our focus was around multi-agency working, understanding flow and throughput, supporting staff, ensuring we have the access to the service right, and wait times, which was the ultimate goal, was to achieve a 4-week wait across our service. Our service is a specialist mental health service for children up to the age of 18, and we offer the an LD pathway, a mental health pathway, and a neurodevelopmental assessment and diagnostic pathway. And one of the key things was getting our partner agencies on board. We only offered a small proportion of the Thrive model, which is the model we adopted in Northumberland, so that getting more help service. So what we needed to ensure is that we have the services at the beginning of the pathway and from a crisis perspective. So everybody working together, working with our voluntary sector, and really reviewing our service criteria and ensure that they were all aligned. The next thing we had to do was look at the capacity. So what capacity do we have in our service, and what are the demands? And looking back over a number of years to see at different points, we would see trends, and how could we manage those trends leading up to school holidays and things. So that really helped us understand what the demands we thought would be on the service every year moving forward, and then the capacity we had to meet that. And ultimately delivering a service as per our service specification to enable us to achieve what we wanted to achieve. Next slide, please. So how did we do it? We took some of our staffing resource into the front end of our service. So it was around staff with mental health skills who are significantly experienced in working with children and young people, but also understanding the community around us. We front load the front end of our service, and we offer telephone consultations, paper referrals, link with our multi-agency partners and have an interface with them around ensuring children's needs are met. So there's no wrong door. So we kind of agreed across the partnership with one multi-agency that if a referral went to them, we would all ensure that it got to the right place. Those clinicians at the front door will accept young children, and then they have an initial assessment with a senior member of staff. And this was to ensure that we are allocating to the right clinicians with the right skills. I think all of services have tried to manage waiting times in the past, and we'll have to ensure that it's the right person that's working with that child with the right skills to ensure that throughput. As I've already mentioned, a really robust emotional mental health interface meeting with all agencies, and then that ability to signpost. Across our service now, the mental health pathway and the learning disability pathway, we are achieving a 4-week wait that is to treatment. So that's 2 appointments, and our neurodevelopmental pathway is an average wait of 7 weeks for that assessment to start. Just going into the pandemic, we never thought we would hit a pandemic in the middle of this process. We were achieving 4 weeks across all pathways, but I know there's significant demands around those assessments, particular autism and ADHD across the country. The key thing a change we made was every child leaves their appointment with the next appointment. So we have allocation appointments available. Every clinician in the service, so they are mapped out for the year. So we really understand our capacity and demand and are able to map that out. The other key thing was supporting staff. So through management supervision, job plans where there's an expectation around the amount of contacts that clinicians will deliver, clinical supervision, a variety of MDT forums, and a really robust transition programme, and a bespoke induction about working within our service. And then we've got appraisal as well. Caseload management is a key thing within our service, and our RIO system, which is the IT system we use, pulls information. We have a SIPS staff supervision matrix, and we can monitor and discuss with clinicians goals that young people and clinicians have set. And so, for example, if a young person came in and they felt they were at a 2 around their anxiety and now they were at an 8, we would then be able to look at that discharge plan moving forward. Every member of staff has 1 day per month, a dedicated protected time where they can look at their caseload management form, be prepared for that, and then look at kind of throughputs or any challenges. All of this takes constant monitoring, and I think everyone knows that things can slide really easily. So using systems and technology really help us to monitor this. Next slide, please. So the system we use is RIO, and that's where referrals are opened, and this is our electronic health record. And with the fantastic performance team we have in CNTW and IT, we use RIO to give us the data we need, which then releases capacity to care and look after children and support that more face-to-face appointments, because the data is at the end of our fingertips when we need that, and that's live. So we can monitor and look at the referrals coming in, how many discharges are going out, how many referrals are going into each pathway, when they've had their first contact, when they've had their second contact for treatment. And back a few years ago, when Simon visited our service, we talked about how can we monitor those internal waits. And just like every service, we've probably had Excel spreadsheets and things, how we monitor these. But actually, with the hard work of our IT colleagues, we've been able to develop a patient tracker, which we are now embedding. As a service, we wanted to ensure that if we had a 4-week wait for access, we also wanted a 4-week wait for those specific therapies. So a child might be in the service having care and treatment from a care coordinator, but it may be that they need EMDR or CBT or a neurodevelopmental assessment, and we wanted to ensure that we could achieve a 4-week wait for those requests as well. So using all of the knowledge that we have now, the systems that we have, and the robust support that we've got for staff, this has improved patient waits and flow, and ultimately improved the patient and family's experience. So thank you very much, and I'll hand you on to the next speaker.
Thank you, Katie. It's always inspirational to hear about the work that you guys have done. It's amazing. So I'm going to bring back in Dr. Ian Davidson to talk about red to green.
Hi again. So building on that and building on one of the questions in the chat box, if this is going to work, we need to have flow through. And easy in, easy out requires that we can discharge people as well as accept people. And one of the big barriers to discharging people is that we're not very clear in general in mental health at what point the person no longer needs our input. And this can become a big issue. It becomes an even bigger issue if people believe that if they are discharged, they will not be able to get back in. And if primary care believe that if someone's discharged and something starts to go wrong, they will be left with that problem with nothing to back them up. So easy in, easy out depends on flow. It depends on people having got to the point where they are able to say, yes, we no longer need your service, but we can say, and if you do need it again, you can quickly get back in. So red to green is a flow tool approach. It's a very simple approach. In inpatients, it tends to be done daily. In community teams, it will be done when you're doing your team reviews, depending on how you review each case on your caseload. But essentially, green is that all the things that we expect to be done are being done and they're going to plan. So to start this off, you have to be very, very clear. What's the purpose of this person accessing the team? What is it that it's essential that they need that cannot be delivered by other services, but that we need to deliver? So that's the purpose, and we need to focus on that purpose and then how we achieve that. There's a tendency in mental health to say you need this therapy, you need this medication. It's not true. What we know in our services is that none of our interventions work for everyone. All of our interventions cause issues and can cause harm to some people. In general, our interventions are extremely successful and we're probably achieving at least as good outcomes as our physical health colleagues, although we don't tend to record them. But we need to be very, very clear. Not everything we try will work first time. Therefore, red to green is, if it's not going right, is it not going right because we didn't do what we planned to do? For example, the internal waiting list that have just been discussed. Is it not going right because we tried to do what we were trying to do, but actually it's not working out as we hoped? Is it not going right because it's not acceptable to the person we're trying to help and because they don't see it as being a right way of helping them? So red does not imply fault. It implies that the plan is not going. Green says, yes, it's all going well. The purpose of admission into the team has been achieved or is being achieved according to timetable. And if you think of it in terms of roads, green is you're driving along the road, you're hitting every traffic light green, and you get into your destination smoothly and without delay. Red is you're going along that road and periodically the traffic lights are going red, and currently some of them stay red for a very long time, and we need to be addressing that so that you're hitting green lights. In relation to this, it is therefore very much about for each person knowing what the purpose is. That purpose should have been agreed with them, and there should have been a proper assessment before they came into the service, or at least when they came into the service. We have got very poor at taking proper histories when people come into services, which often leads to inappropriate misunderstandings along the way. So you need to have a proper assessment, but then you should not be repeating the history over and over again. That's one of the things that uses up a lot of time and frustrates people and their families, is we ask them the same questions over and over again. That's very traumatizing and a bad use of resources. So again, if you're doing that, if you find you're doing multiple reassessments, you're on a red. That's not good practice, that's poor practice. Why do you need a multiple assessment? So it's a very simple way of doing this, which then generates the sort of information that has just been discussed, which you can feed into are the people who are coming into our service getting what they need in a timely manner? Is it proving effective? Are we able to help them as quickly as possible reach the point they no longer need us? And are they leaving us with a guarantee that if they need to come back, they can come back quickly without having to go through all sorts of rigmarole to get back in? And if you can do that, then you've got a green, good flow pathway. And I'll stop at that point.
Thank you. Thank you very much. So at this point, I'm going to bring in the newest member of our team. Welcome, Caroline Attard. I'll let Caroline introduce herself.
Thank you, Simon. Yes, I am the newbie in the team. I've been in the team for 2 weeks, but I'm glad to say that I'm not a newbie in improvement work. So I have over 20 years experience in working in mental health. I'm a mental health nurse by background, and the last 10 to 15 years I've dedicated most of my career in driving improvement and improvement methodology. So I'm going to be doing a section on using data for improvement. So after hearing from Dr. Davison and Katie, I'm sure you've been inspired like me in terms of how to do this on the ground, I suppose. But we need to step a little bit back to start thinking about what also we need to do in the organization to get patient flow. And there are a suite of things that we discussed in quite a bit of detail around what we do at a team level, but there are other things, especially around data management. So as you can see on the slide, on the right hand side, you have the triangle that demonstrates an organization, I suppose. I'm aware that is not as neatly, each organization is not as neatly as it is on the slide, but it's to demonstrate that information flow, and especially patient flow, needs to flow up and down the organization in a structured way. So we spent quite a bit of time discussing around case formulation and case supervision and the importance of that with patient flow. It's also really important to think about how team huddles or stand-ups or report outs, depending on the quality improvement model that you use, how that is used to drive and use data to drive information up the organization at service governance meetings, locality governance meeting, at the trust strategic quality and operational meeting, up to the board and also the ICB. As you can see, the arrow goes also down because it's important that it flows up and down and not in one way only. On our future NHS page, we have a self-assessment checklist that Simon have mentioned before. This is really helpful to dig a little bit kind of deeper into what I've just said and almost like use it. I like to use it as a checklist to make sure if those things are present when I'm working in this way, and if they're not, what you need to do to move towards that. So on the other side, we'll start digging a little bit deeper as to what each level of the organization almost needs to have that effective line of sight. I like to think about it as a golden thread between board to floor and floor to board. So where the work happens at a team level and all the way up to the board and back. So we need to have a clear definition of how data is to be aggregated and reported at each level. This is pivotal, really, to get a patient flow. We also need to have a very clear accountability of what happens when data is seen at each level. So almost like an understanding, a clear understanding of a risk profile or tolerant at each level. But also ownership and what happens when the data is seen. Together with this, also an escalation process. There are tools that help with escalation, but you might have a process of how patient flow is highlighted up the organization and again back down. Clear lines of assurance and deliveries, especially at a strategic level, but also at a service level. As we said, a board and an executive oversight of how data is seen, and is it aggregated, is it not? This is really important. I'm sure you, like me, you've been in some situations, but where there have been astronomical data points of how data is seen and how resources are deployed because of what is seen is really important to be defined. With this, a standard work agenda or reported structures is really important, and is defined beforehand. And lastly, to focus on outcome, not process, because the process is done by us. So we have the opportunity to influence how the process is done. Next slide, please. So this slide is to get us to think and reflect on how we use data and how to report some of what we spoke about. So, for example, referral rates and waiting times for services. How do we report how many patients receive each intervention for specific treatments? How do we report on discharges and transfers, patient progress against pathway expectations, and the variation in duration of treatment? How do you report on reasons for delays to access and move through pathways, or do you report that? Other thinking points, where does the information report to? So as I said earlier, that line of sight between board to floor and to the system, and how are issues or concerns escalated, and are they escalated? What level of focus and granularity is it reported in each level? And who is responsible? Are there responsibilities of different groups as to how escalations, threshold mechanisms are reported to all parties? So this is the point that I would like us to pause a little bit and get some of you to volunteer as to what you've heard so far, or maybe some reflections around what you're seeing in front of you now, so some thinking points, or also if anyone has done this before, we know that sharing is one of the most powerful bits that we have, so it would be good to have that. So if anyone would like to, so we have about 10 minutes maximum. So of course, not everybody can do that because we're over 150 on the call, but it would be good not to leave me alone for the next 10 minutes. So if you would like to talk, just raise your hand and I'm sure one of my colleagues will unmute you. Brilliant. Okay, so to end with, these are some metrics that would help when you're defining some metrics, but of course it needs to be defined at a local level. But we know through the work that we do that some of them will might help in terms of how you define them. So some questions that we find that will help you to define some of these metrics that you're seeing in front of you are as follows. So are there pathways where you need to consider implementing a different way of working to support people who are waiting a long time? It's a good question to start asking. What is the Pareto analysis for reasons for delays telling us, especially around management supervision on extended treatment reviews? What is it telling us? And whatever is telling us, how are we going to deploy, I suppose, our improvement resources towards it? Where patients are staying for a long time in the pathways, what is the distribution of the numbers, demographic and clinical terms? What is being offered? Is it equitable? Do we need to do anything about that? What is the patient experience telling you about how movement in and out of the services or out of a pathway feels? That's always a good question to ask to try and define a metric. What is staff experience of working in this way telling you as well? So these are some of the examples just to summarize of what you could ask to define some of the metrics, but of course it needs to be collected locally. So that's it from me, and I'm now going to hand over to Dr. Davison again.
Thank you. So trying to build on all of that and link it all together. One of the questions that came up was how do you sort of get your board moving into thinking about forward planning rather than reactive crisis mode? One of the things that's very daunting when you hear some of these talks is how much you need to collect and how little we're currently collecting, and it can be very daunting to think, where do we start? So what we've got here is stuff that is currently routinely collected and is routinely published, which actually helps you to look at whether or not your community flow is working effectively. This is system flow. So if it isn't working effectively, it's not necessarily saying it's the trust is not making it work effectively, but it's about whether your system is effectively flowing in your ICB. This is data that's currently available. It's published. Anyone can look at it. Your trust board can look at it. Your senior manager can look at it. If you're not moving this stuff in the right direction, then you're not actually achieving systematic change and systemic change. So this is some stuff. High use of section 136. This indicates that the police are having to bring people to mental health services attention where they are concerned about them. That indicates that people are not being able to come in through the front door and get proper advice and support. All sorts of reasons for that, which if I was doing a GIRF deep dive, I would talk through in detail with you, but it's a high-level sentinel metric. These are sentinel metrics. They indicate there are things below this that need further looking into. High use of section 2. The vast majority of people who get admitted to hospital are already well known to services. So why are we bringing them in for assessment? Why are we saying we don't know whether or not they've got a mental disorder or they've got a mental disorder that requires treatment? And why are we saying that it's not honest to the people that we're bringing in, because what they invariably find is they almost certainly end up in treatment, and it's not honest about where we are. And so we need to be looking at that. High numbers coming in through A&E. Again, why are they having to come to A&E to get into the service? Why can't they come through your front door? And that indicates that you're failing to engage with your local community. And this is a system issue. There are all sorts of things behind this, but it's about digging into it. Why are people not coming in through routine referral route? Why are they having to go and present in crisis to A&E as their first point of contact? We've already said that presenting in crisis is a bad time to present. It's a difficult time to get a proper history of people. It's a difficult time to properly plan with people, because everyone's in a high arousal state. So you're not thinking straight. They're not thinking straight. Their memory is all distorted by the crisis they're in currently. So you will not get an accurate history. It's just the wrong way to come in. High numbers coming into mental health service for the first time through the Mental Health Act. Again, why are they having to get to that stage of being seriously ill to the point where they're going to have the liberty deprived of them as the first point of contact with the mental health service? There is something seriously wrong with the access routes in that time. And like I said, we've got lots of stuff we can talk about with you about how you can look at that and segment that and start to identify the ways forward. Differential Route 1 access. This is where people say, oh, we've got lots of people from these marginalised and excluded communities on our caseload. But the key test is, how do they get onto your caseload? Did they come in through a clear referral, seamless passing up? We've identified they've got an essential need, they need more intensive input, they're getting that intensive, or did they come in through the routes above? Because the marginalised and excluded groups tend to come in through the routes above. They tend to come in with higher acuity. They tend to come in when they develop secondary and tertiary harms, and therefore they tend to end up having a much more severe condition to treat and less chance of getting back to the previous level of functioning. So differential Route 1 access is really crucial. Route 1 is the smooth route in, where you're brought in before you've reached any crisis point. These things are on the model health system, and there are also lots of this information is on the dashboards on the acute mental health website that's been referred to earlier on Future Healthcare. So tons of information which you can drill down to all sorts of levels. Next slide, please. And then these are about flow. If you've got high rates of discharge without assessment, i.e. what used to be called not appropriate, okay, if you're getting loads of referrals where you're saying this person's not appropriate, there's a big system problem. We should never be doing that. That's the old-fashioned bouncer approach of, you don't fit the dress code, so go away, please, and leave us alone. If people are coming in, if they're being referred, then what we need to be saying is even if we're not the best team to help you, we've listened to you, we've heard your problem, and we're going to put you in contact with the best service to deal with you. And too many people experience multiple fob-offs at that point. Too many GPs just get lots of bounce backs, not appropriate, but no one actually saying what is helpful. You can capture the information about how many people that you see and transfer onto other services, because that can help identify gaps, but you should not be bouncing them out with just saying you're inappropriate. It's devastating as a human being to be told that you're inappropriate. I mean, if you're already low self-esteem, already depressed, the last thing you want to be told is you're inappropriate and you're wasting our time coming here. That does not help anyone's mental health. Large caseloads with low turnover, particularly where there's no clear purpose or outcomes. If you're not using red to green or anything else, if you don't know why you're still seeing this person after a year, you don't know whether or not they're better than they were at the point they came in, you don't know how much input they need to keep well in the future, then you've got a big problem, because you've really got everyone just bogged down in a slow sludge, which is not helping anyone. It burns people out, and like I say, it leads to stress, because then you're trying to get a few people out quickly, and you're sometimes kicking people out before they're ready, et cetera, or you have long waits. So it's about really understanding that. When we did red to green on inpatients in the trust where I was working at that time, what was really important was anecdote does not actually make good planning. The anecdotes at that time were that all the long lengths of stay were due to things like care packages not being agreed, social care providers not providing housing. When we actually did red to green, they were the 6th most common cause. The 5 top causes were actually in the internal control of our services. So we need to use anecdotes and qualitative stuff to pose the questions, but then we need to be using the data to look at whether or not those questions, what are the answers to those questions. Similarly, long inpatient lengths of stay, over 60 days. We now know that the longer you're in hospital, the more harm it does you. And over 60 days is arbitrary, but certainly over 60 days, you're starting to get into the situation of, can we justify the harm of keeping this person in hospital? What good are we doing that justifies that harm? And when we started to look at that now in work I've been doing through the GIRF stream with people, what again, it all came out was, oh, it's all about housing, it's all about social care. When we actually have analysed that in various trusts, it's turned out to be a very small proportion of those days are due to those things. Most of them are due to not getting people treated quickly enough and effectively enough, which in turn leads back to the coming in too severe a state and all the rest of it. So it's over 60 days length of stay. If you've got high over 60 days length of stay, it's a real big indication that your flow through the system, right from the front door, right through your community team, right through crisis and home treatment, that flow pathway is not working effectively. Long waits, as has been referred to earlier, it's all very well getting assessed, but if you're then told you're going to wait 3-6 months to get something, you are likely to deteriorate in that time, and you're likely to end up in crisis again. So again, those things are all available. High DNA rates at the moment tends to be reported by trusts only for clinic-based appointments. We would like people to move to doing this for failed contacts in the community as well. But if you're getting more than 10% new appointments not taken up, there's a really serious issue between you and the people referring into you about understanding why are people in your community not taking up that offer. And if you're getting more than 5% failed appointments for follow-up, then it's really saying there's something wrong with the offer you're making to the community, and you're not proving yourself to be interesting enough, useful enough, or accessible enough for them to turn up. Don't forget, we are paid to engage with people. They are not paid to engage with us. Therefore, if we're saying that someone's non-engaging, it's actually a question to ourselves. Why are we not engaging these people? And across the country, people start to do some really innovative work and go out and talk to people. As you know, mental health collects more data on people than anyone else does in the world, including Amazon and Google. So we're starting to use that data and look at which GP practices, which postcodes, which communities, which sub-communities, and go out and ask them, what is it about the access that is so difficult for you, or why is it that you're so concerned about being discharged in case you can't get back in again, in order to do that, because that's the only way to get easy and easy out. And as we said multiple times, multiple assessments are an absolute waste of resources. They are actually very insulting to people. They make people feel they've not been heard. They make families feel they've not been heard. And in terms of trauma-informed care, asking people over and over again about horrible things that happened in their lives is a very good way of inducing trauma. So we need to cut them out. We need to have a good assessment at the beginning, getting it right first time, and then only build on that or modify that as things change. You know, I'm well into my 60s, as you can see from the picture in front of you, and what school I went to, what age I learned to walk and talk, what my first job was, they don't change. Okay, we don't need to keep asking people all those same questions. Thank you very much. Next person.
Thank you, Dr. Davidson, for a brilliant summary of the issues in a much clearer and more articulate way than I'd be able to manage. Can we have the next slide, please? So leading on from what you've just heard, reaching a sustainable, balanced patient flow position may require significant medium to long-term work on pathways, workforce skill mix and finance, but effective patient flow management processes can still be used in the immediate short term to begin to improve a stuck or deteriorating position. So the sort of scale, we would very much advocate that the sort of scale of change does not hinder getting started with some of this. The practical steps for reporting on and addressing the issues for each of the elements that relate to patient flow are co-produce local standards, identify lines of reporting for what is happening against the standards we set, identify where in the governance the accountabilities for different aspects of improvement work lives, and document it all in standard operating protocols and policies, and support whatever bits of it need to be operationalized with training and supervision and coaching, etc., for the leaders that are responsible for that. Can I have the next slide, please? So in terms of getting started and who needs to do what, as we said earlier, you know, this is a significant culture change for stakeholders that needs lots of different aspects of engagement. So from a commissioning and provider collaborative perspective, we need to map the system offer, making sure there's no commissioning gaps, work with patients around value stream mapping, so understanding what each bit of the treatment pathway feels like and whether or not it feels useful or harmful. Working out what the governance around overseeing the delivery and any improvement actions are going to be, and that needs to include inter-organizational working arrangements and who's going to be leading on which bit, etc. And agreeing standards around waiting times and discharge, etc., with patients, and really taking ownership of the change of culture and experience. So, you know, to get to that point of clinicians and patients being confident that the mental health offer behind their current service is adequately robust and the patient will be able to step back up into a more intensive treatment if they need to, requires a, you know, sustained working and clear comms, and you know, and sort of celebration of successes and clarity around what we're doing to sort out problems that arise within that. From a provider perspective, it's around standards for care planning, you know, developing processes for reporting, aggregating and escalating data, as we've discussed, having the governance around coordinating the work, and working on what your inter-team and inter-agency working processes are going to be. So, you know, internally within providers, it's around, someone put in the Q&A that point around having explicit clinical support for pathway management approaches, positive risk management, and a model of care that includes patients stepping up and down are really important aspects of your delivery plan. Can I have the next slide, please? So at this point, I'm going to hand over to my colleague, Sean, who is going to talk to you a bit about improvement support.
Hi, I'm Sean Griffiths, member of the team, been with the team for around 2 years. I'm just going to go through some of the support that we can offer and just say that what we've covered today isn't everything around patient flow. So there's other areas that we haven't covered. And some of the ways of working and material that have been described will require significant change in the culture. Carrying out any of these ways of working that we've spoke about, please contact us so we can support you. If you've already carried out some of these and worked on patient flow, it'd be great for you to get in contact with us as well so that we can use you as case studies of good practice. And if you are thinking about carrying out any of the work and would be interested in a working group with other peers, please contact us so we could look at setting something like that up. Next slide, please. Next, we're just talking about, I'm just going to talk about the Futures platform and the kind of resources that we got on there. So one of the major things which has been spoken about earlier was the patient flow checklist. This is a checklist that's been developed by us, and it goes through a lot of different areas and asks questions around areas of inquiry, what you need to explore, and also allows you to document your current position and how you can improve in those areas. The areas such as that we spoke about around case management, supervision, discharges, governance. We've also got resources around the delay codes that you can see documented there around extended treatment reviews and the caseload supervision. Those are outlined there and good examples that you could adapt yourself to use. Next slide, please. We also have resources on letting, well, guidance and examples, just to bear in mind that these are inpatient examples, but they are relevant to community approaches. And we also have links there to the improvement resources, which are mainly around the QSTA programme, and that covers like manager variation, PDSA cycles, Pareto, and I have posted in the Q&A a link to the QSTA page for NHS England, so you can access that. And next, we're just going to be doing some more mentor questions. So if people can get clicking away. The first question is, how would you describe your knowledge of managing patient flow following this webinar? So to get a bit of a barometer of where we are from when we started. You can see now we've got quite a lot of good. A lot of few people are now saying that are good, and that seems like an improvement from earlier. See some neither good or bad, but we're not getting many of the limited or none, which is obviously an improvement from earlier. I'll just give people a few more seconds to, people may have just waking up after the presentation. We can see there's been quite an improvement there from earlier already. Move on to the next question. Okay, what have you learnt today that you feel you could take back and use in your areas to improve patient flow? So this is a word cloud, so we'll get the suggestions coming up of what people feel they have. So the first one there is, we can see, data is key, which we can see in all areas of improvement. We can use that. Red to green in community. If we're coming up, caseload management, caseload supervision. Data seems quite prevalent still, which is good and something that we can all work around. Collaboration, I can see another one coming up. Challenge. That's interesting as well. So I can also see maintaining pathways, data review. There's a lot around data and a lot around collaboration, which is good. And redesign is another one that's coming up. And we can see that these are definitely areas that we'll be able to support as well, and around data and how we use data and where it's collected. And when we say about model hospital as well, that's an area where we work in. So we've just got 6 seconds left of that. Green timescales is another one we can just see there. That's good. Okay, the next question we've got up. This is a multiple choice one. What are your initial thoughts on how you would get started with using these approaches? So we can see this is a similar one that we had earlier with the dots that come up. So we can see there's quite a few different answers there, and around starting with small scale, and yeah, we can see that's one that's came up straight away. And also start having conversation with our partners and addressing cultural change aspects. It's something we spoke around earlier. Start sharing the resources with other partners to see what they think. That's another one that's cool. And we can see the start with small scale, high impact. When we spoke about as something we can support with if people are thinking around these areas, then definitely get in contact with us and we can see how we could support. And there's 6 seconds left of that. Oh, we've also got quite a few for start with other aspects of elective recovery of the programme pathway mapping. So contacting us will definitely help there. And next questions, if we were to undertake other webinars or action learning sets, what would be helpful? So this is another one around selecting all the ones that apply to you. And we can see red to greens, popular approaches for identifying and addressing bottlenecks, fear of constraints. So that's, you know, and change culture as well. Governance is another one that's coming through strongly. So those are definitely areas where we could look at how we could put something together and set or a further webinar in those areas in the future. And that's great that people have taken part in that and we can use that feedback when we're moving forward in the future. Okay, just a 5 seconds left, and then we'll be handed over to my colleague Francis for the Q&A section.
Thank you very much, everybody, for staying on. Thank you very much for your participation. Please do complete the online evaluation survey for improving patient flow webinars so that next time we do one of these webinars, we know exactly how to improve. Please do it for us. Please do it for your colleagues. Please do it for your nation. It only takes 90 seconds using the Dewberry's QR code Dewberry's right in front of you. So please do that while I speak. If you are wanting further links, further information, this slide pack is for you. It will be awash with further information that we could not possibly cover and will be sent to you.
So finally, huge thank you for everybody for sticking with us today. I'm really sorry for running over time. We really did try and keep it to 90 minutes, but really didn't want to lose the opportunity to have some discussion at the end. So again, apologies for encroaching into your next meetings. Thank you very much. We look forward to seeing you on the next one, which is in January. Michael, do you recall what the date is off the top of your head?
You are correct that it's in January. It is on the
10th of January.
10th, Tuesday, the 10th of January.
All right, Tuesday, the 10th of January. We'll see you all for the next one, hopefully. Please do register via the multiverse. I'll send out the slides and whatnot later today and the video over the next couple of days. So thanks again, everybody. Enjoy the rest of your afternoon and happy Christmas to all. Thanks.